All right, so I guess we can get started. So yeah, I'm going to be talking about etiology and evaluation of FUO in adults only. So I'll go through a couple of definitions of FUO and then preliminary workup, and then we'll talk about potential etiologies and more specialized directed workup. So there are two definitions, or two major categories of definitions. The classic FUO definition at Petersdorf and Beeson back in '61, which required you to have a fever of 100.9 on several occasions for at least 3 weeks, despite a week's investigation in the hospital. And then that inpatient requirement was removed. More updated definitions from Dirac and Street in the 90s divided it into 4 major categories based on patient characteristics. So there's the classic nosocomial, neutropenic, and HIV related. So classic was similar to the original definition. You have to have the fever for 3 weeks, but without a diagnosis, despite 2 outpatient visits or 3 days in the hospital with workup. Nosocomial was the fever 3 days not present on admission. Neutropenic is in the presence of neutropenia. And that's actually, so the IDSA guidelines define severe neutropenia as an ANC below 500 in negative cultures, blood cultures. Then HIV is in the setting of HIV infection. So all patients, before you can call something an FUO, you have to have at least this preliminary workup, which has to be unrevealing. So history and physical, the CBC, CMP, and hepatitis serologies if the LFTs are abnormal. 3 sets of blood cultures, which we'll talk about in a sec. The urinalysis, a chest X-ray, and HIV testing. So if all of that is negative, then you can consider something, and the appropriate time has elapsed, then you can consider something an FUO. So blood cultures, I wanted to just make a note here. It's important. So first of all, how many should you obtain? So the previous slide we said 3. The answer is never 1. If you can't get 3, at least try for 2, but 1 really puts, can make it a difficult situation if you get an organism that could be a contaminant or a commensal organism. So then it becomes very difficult to try and sort out, is it a contaminant or is it a true pathogen? And in the literature, if you find this is the rate of positivity. So if you get 1 set, you have about a 60 to 70% chance of isolating your organism. 2 sets, it goes up to 89, 3 sets, almost 100, 98%, and 4 sets, it's nearly 100%. So there's some diminishing returns with the more sets you do, but generally 3 sets is what you want to really give it your best shot at isolating an organism. And then how much, because this often gets overlooked. So when you're drawing blood cultures, how much volume do you actually need? You need at least 5 mLs. 8 to 10 is optimal, but sometimes very difficult to get. And then beyond that, beyond 10 mLs, there's really been no studies that have found that increases the yield very much. And your yield decreases by about 3% as you go for each ml below 10 mLs. And then how often and when do you want to draw them? So there really is no relationship between blood culture positivity and fever. A lot of people say draw it at the time of the fever, but that doesn't really hold true. You always want to try before antibiotics if it's feasible. Number 1 cause of culture negative endocarditis is previous antibiotics, actually. And like I said, the timing with fever is not really correlated to positivity. And you want 2 to 3 sets, like we talked about, from different sites. And if you get them simultaneously, like, one draw after the other, it's probably fine. There is some data that says you can space it out 4 to 6 hours in case of intermittent bacteremias, but that's fairly uncommon. And you don't really need to do that for the patient's sake and your sake. It's easier to probably just do them all around the same time. And yeah, most bacteremias are continuous and low grade rather than intermittent. So spacing them out doesn't really make too much difference. Yeah, so just to give you an idea, most of the blood culture bottles have little volume markers. So you can look at it and see what the optimal fill volume is. And that 8 to 10 is the sweet spot. And this is just a slide showing a study that this is the timing of the blood culture with relation to Tmax, and an hour before or an hour after, or 24 hours after the Tmax, and the positivity rate, and really no major difference in positivity rate. So we're showing it doesn't really correlate with positivity and fever. So as far as etiologies, this is older data, and this is actually only in, I want to say these excluded any patients with immunocompromising conditions, HIV, pediatrics, obviously, and this was only done in Asia and the Americas. So Africa and Europe were sort of left out of these cohorts. But infection has always predominated. As we get into the 90s, there's more and more connective tissue diseases being diagnosed. And then there's always a large chunk of miscellaneous or undiagnosed, which we never have an answer for. But by and large, the three major categories are infection, malignancy, and connective tissue diseases. As far as infections go, the most common worldwide is definitely tuberculosis. And then intra-abdominal abscesses, occult abscesses, are the next most common worldwide. As far as malignancies go, non-Hodgkin's and Hodgkin's lymphoma are the big ones. And in those case series, actually, temporal arteritis was a major diagnosis. It's diagnosed in almost 16 to 17% of elderly patients. So this is a little bit newer data from the 2000s, different case series. And again, these excluded immunocompromised patients, people with HIV, pediatrics, and geographically, for whatever reason, there really haven't been any cohorts out of the Americas and Africa. It really focuses on like the Middle East, Asia, and Europe. And then they varied also in terms of which definition of FUO, either the classic or the more updated definitions that they've used to define FUO in these cohorts. But by and large, I think people used the classic definition more often. And so this is the bottom line, basically. About 3,000 patients over these 18 case series from the mid-2000s, and infections were the predominant etiology when you found an etiology, about 37–38% of the time. And then non-infectious inflammatory diseases, so that would be autoimmune diseases, autoinflammatory diseases, connective tissue diseases, vasculitis, and then no diagnosis, made up almost a quarter of the cases, and then neoplasm was there as well. And then in terms of specifics, infectious diseases, mycobacterial, so TB, far and away the most common, almost 37% of the infections, followed by endocarditis and brucella. As far as neoplasms, again, lymphomas predominated almost 60% of neoplasms. And then non-infectious inflammatory diseases, adult onset stills made up almost 30% of the cases, and then lupus coming in at around 11%. And just to show these, so it varies depending on the geographic area, the socioeconomic status of the patients, which criteria you look at, and then the model of the study is retrospective or prospective. So, like, for example, brucella, if you don't look at the Middle East and Southern Europe, brucella is not going to make up a large part of your FUOs. So talk a little bit about etiologies in specific populations. Nosocomial FUO, you have, post-operative FUOs, and fever is quite common post-op. Almost 40% of patients will have a fever. And we rarely find the specific etiology, and it generally resolves spontaneously. If there is infection, it tends to present early in the first few days of post-operative status. The one exception to that is an abscess, so intra-abdominal abscesses after GI surgery will present a little bit later, like a week to 2 weeks afterwards. And generally these fevers post-op maybe, they may be an inflammatory response to the procedure and cytokines. Fever in the ICU, very common, multiple potential etiologies besides infection, lines, tubes, VTE, drug fever. As far as infections go, commonly overlooked one is sinusitis, and in some cases, it was a sole cause of fever in 16% and a contributing factor in 13-14% of patients with an FUO in the ICU. Especially so patients who've been intubated for a while, who have nasogastric tubes. And in HIV and AIDS, there's very limited data as far as FUO and people living with HIV in the modern antiretroviral era, so 2010 plus, when we've really had very effective antiretroviral therapy. In most case series, the median CD4 is less than 100, so these are AIDS patients with severely compromised immune systems. And infections are far and away the most common cause of FUO. Worldwide, again, tuberculosis is the most common. TB can have a very atypical presentation in HIV. There's a lot of extrapulmonary TB, disseminated TB, especially when you get to low T cells, less than 50. And even pulmonary TB can present atypically in people with HIV, and the radiographic appearance of TB can vary really widely. You can actually have a normal chest X-ray and still have TB. Disseminated MAC is the most common in the US and Northern Europe. And then PCP and disseminated CMV. All of these have really become much less common nowadays with really effective antiretrovirals. And then, the endemic mycoses like histoplasma, cryptococcus, coccidiomycosis. Visceral leishmaniasis, if the patient has a history of living in those areas, so the Middle East and Southern Europe, certain areas of South America. Malignancies don't make up a huge portion of FUO and HIV, about 8%, and it's mostly lymphoma. So additional workup for FUO in patients with AIDS should include mycobacterial blood cultures. Tissue sampling really is important. So any enlarged lymph nodes, if there's cytopenias, then a bone marrow biopsy. Skin lesions should be biopsied if present. And if there are neurologic signs, then CSF should be sampled as well. And an ophtho evaluation is helpful because CMV retinitis and CMV eye disease can be subclinical early on, but it can be a clue to disseminated CMV disease. And this is just breakdown of specific etiologies. So DMACs are disseminated MAC, most common, and this is a cohort from the U.S. PCP, CMV, histo, other viral infections. Yeah, and then lymphoma making up about 7 or 8%. Neutropenic FUO. So neutropenic fever is generally short-lived at the time of most severe neutropenia. And then of infections, bacterial, your typical bacterial pathogens are going to predominate. If you have sustained neutropenic fever in the face of broad spectrum antibiotics, you have to think of a fungal disease, Aspergillus especially. Yeah, and so if you have a neutropenic patient who's not responding to antibiotics, so fungal infections predominate in about 40%. You also a bacterial infection with a source that hasn't been identified, so like an abscess, intra-abdominal abscess, or a catheter device-related infection are probably the next most common. Parasitic and viral infections are not too common in the neutropenic patient, making up about 5% each. And then a lot of times you have undefined fever, drug fever, or toxic effects of chemotherapy. And those are diagnoses of exclusion. Transplant, so these people are severely immunocompromised, and there's actually a lower threshold for defining fever in the transplant population, so it's only 100 Fahrenheit, 37.8 Celsius. Again, infections predominate. Bacterial and disseminated fungal disease are the most common. Viral diseases, certain viral infections do play more of a role in the transplant population, especially CMV and HHV6, which causes like an encephalitic type picture in transplant patients. Graft rejection is a big one for solid transplant, solid organ transplant, and bone marrow. Usually occurs early post-transplant. And then malignancies often happen late post-transplant. And then drug-induced is a big one with the immunomodulating drugs are common causes of drug-induced fever. Fever in returning travelers, really worldwide it's malaria, but it can really vary widely based on specific exposures, where you are, what type of prophylaxis or vaccines you had, and then the host's immune status. This is a case series looking at fever in return travelers, and malaria Malaria is the most common, 30 to 40%. And then you have a whole, a variety of other infections. Some of them are not so uncommon, just regular respiratory tract infections, pneumonia, flu, and then UTIs and pyelonephritis. The incubation period is a good clue. So most viral rickettsial infections will occur within 21 days. So if you have a late onset, you don't really, things like dengue fever and other, tick-borne infections are not really going to present that late out. Someone has a fever 30 days after they return. It's unlikely to be that or malaria. This is a great article to refer to in the New England Journal, Approach to Fever and Returning Traveler. So they have it broken down by geographic location and the most common infections in each place, and also the clinical syndrome that the patient's presenting with. So it'll like fever and rash, respiratory, GI symptoms, and then the most common for each of those. So it's a really good article to look at if you have someone with a travel history and a fever that you can't figure out. This is just a summary basically of classic nosocomial and neutropenic and HIV-related FUO and the leading causes, investigation and management. Won't spend much time here because we went through everything. So as far as inflammatory diseases, in Western countries especially, our diagnostic tools becoming better. We're seeing, they're making up more and more of a percentage of FUO cases. Most common non-infectious inflammatory diseases in Western countries, so Europe and the US, are Still's disease, large vessel vasculitis, lupus, and sarcoid. And in Southeast Asia and Africa, Still's disease is still the most common, followed by vasculitis, polymyalgia rheumatica, and lupus. As far as autoimmune diseases go, in a variety of FUO cohorts, lupus has always predominated throughout the years. And in terms of vasculitis, as you see in non-Western cohorts at the top, PMR predominates, and in Western cohorts, it's more large vessel vasculitis. And autoinflammatory diseases worldwide, it's Still's disease is the most common. And there's a variety of other rheumatologic diseases that have been found in these FUO cohorts: reactive arthritis, pseudogout, gout, psoriatic arthritis, but they make up a much smaller percentage overall. So in terms of workup, this is a good article to refer to. It really kind of gives you almost like a flow chart to go by specific clues in the history or physical, exposure history, labs to look for, what to order. So it's something that I refer to pretty often. History, obviously very important, very detailed exposure history, animal and animal products, which give you clues for infections like Q fever, brucella, or Mycobacteria bovis. Travel, and when you ask about travel, it's not just where they've been, but what specific activities they've been doing in those locations. So like freshwater sports, your risk for leptospirosis and certain other tick-borne diseases if you're hiking or in wooded areas. And it can get very specific in terms of location. Altitude often plays a big role, especially when you're talking about mosquito-borne illnesses. So you really want to nail down exactly where they've been and for how long. Occupational, needle stick injuries could be a clue for hepatitis. Obviously, a sexual history for HIV, syphilis, certain, any that started in new medications for drug fever, blood products. So not so much of an issue nowadays, since the early 90s when all the blood products were screened for HIV and hepatitis. But you do occasionally still see cases of transfusion-related babesiosis in the Northeast. So something to always just keep in the back of your mind. And then any recent invasive procedures, especially in people with prosthetic heart valves or any prosthetic joints or prosthetic material, basically, which can get seated. So dental procedures, surgeries, endoscopies with biopsy, especially. Family history, which should include a malignancy, autoimmune disease, or immunodeficiencies, and a personal infectious history for the patient, so that you can identify sometimes potential immunodeficiencies or periodic fever syndromes. If you see a pattern in the type of infections that patients are getting over and over, if they're repeated sinopulmonary infections, that can give you a clue to immunoglobulin deficiency. And there's certain other infections that are sort of are more strongly associated with different immunodeficiencies. As far as the physical exam, beyond just a careful physical, areas you want to spend particular attention on are the head, so sinus tenderness, temporal artery bruise, ulcerations or conjunctival lesions, neck for any nuchal rigidity, which hopefully should be pretty obvious, or adenopathy. And don't forget occipital and pre and post auricular adenopathy, which can give you a clue to a head and neck pathology. Chest, obviously heart murmurs, friction rubs for endocarditis or pericarditis. Abdomen, spleen and liver size. A GU ulceration or GU examination is important, especially looking for genital ulcerations or lesions. Often gets overlooked. Perirectal ulcerations, lesions, or abscesses, especially in the ICU patient who can't give you a history or point to things that may be bothering them very much. People who've had rectal tubes for a long time are prone to get perirectal abscesses. And then skin, you always want to do a complete skin exam as much as you can, looking for rashes, eschars, petechiae, which can give you clues. Extremities, so joint exam, and if they have a joint that does hurt, you really want to range the joint and see if the inflammation is in the joint capsule itself, or if it's muscular in the area around it. Janeway lesions, which are the painless macular lesions on the palmar surfaces of your hands and feet, and osselar nodes, which are the painful lesions. Splinter hemorrhages, and always check the feet for all of these too. Splinters are actually pretty common for a variety of reasons, not just endocarditis or bacteremia. But if you are examining the patient repeatedly through the course of their hospitalization and they develop splinters, that's more of a clue that they are bacteremic, rather than if they just come in with splinters, which could be from trauma or anything. So specific labs beyond your routine, CBC and CMP, most literature does not support just kind of a shotgun approach to different serologies and things. It really should be based on specific exposures. A heterophile antibody and a CMV IgM can be helpful for mononucleosis. CMV is the most common cause of heterophile negative mononucleosis. So most common cause of mononucleosis is Epstein-Barr, which will give you a positive heterophile. But in the absence of that, CMV IgM should. That's the second most common cause. ANA, rheumatoid factor, ferritin give you clues to autoimmune or autoinflammatory diseases. Tuberculosis, so interferon gamma release assay, can be helpful. It doesn't say anything for sure, so you can definitely have a negative IGRA and still have tuberculosis. But if you do have a positive, it should maybe make your search for TB a little bit more, it should move it up on your differential, I should say. And then ESR, CRP, and procalcitonin can be helpful to distinguish between infectious and non-infectious etiologies. There's been some literature or research done on CRP and procalcitonin, especially to distinguish between bacterial and other non-infectious etiologies. So there's this meta-analysis from 2017, which included pediatric and adult studies, and they sort of varied in their cutoffs for both markers. Most of the studies in the meta-analysis used a procalcitonin of more than 0.5 and a CRP of over 8 to 20. So for procalcitonin, they did find that when they used a cutoff of 0.5, that you were more likely to find non-bacterial infections, or sorry, if it's less than 0.5, bacterial infections were much less common. And then so the sensitivity and specificity when you use a cutoff of 0.5 for bacterial infections is around 80 to 85% for procalcitonin. For CRP, so same, using the cutoff of 8, less than 8, much less likely to be a bacterial cause of your fever, but a sensitivity of 70, basically 70%, specificity of 75. In terms of imaging, so CT of chest, abdomen, and pelvis is generally recommended as part of your workup if everything else has been negative so far, because as we said, occult intra-abdominal abscesses are one of the leading infectious causes of FUO, and it's a pretty helpful test. So false positivity rate in one study was up to 20%. But that varies depending on the patient characteristics. So it varies quite a bit. Nuclear imaging, something we use fairly often, I would say, in terms of FUO, like a gallium scan. The gallium will help you localize a source of infection, but you need specific imaging to identify exactly what's going on in that area afterwards. PET scans, other countries use them more often than we do. It's impossible to get a PET scan inpatient here. But there's fairly good data that says that they are helpful in terms of FUO. In some studies, so in 33% of cases, they were clinically helpful. They tend to, if someone's having continuous fever rather than periodic fever, so periodic fever, meaning like fever for a few days, then off, and then next week having fever again. You're not as likely to find something on the PET scan. And if someone has a normal ESR and CRP, they were found to be not very helpful in that setting. Um, so in this series of 136 patients, PET scan was positive in 71% of patients who a final diagnosis was ended up being made, and it was helpful in finding that. And predictive markers for a diagnostic PET scan were older age, so over 50, a high CRP over 30, and actually the absence of fever. So maybe more useful in the outpatient setting, because you're, as I said, you never get a PET scan inpatient. So other studies that you can do, some studies recommend a temporal artery biopsy in elderly patients without a clear diagnosis. Lumbar puncture, even if the neurologic signs are subtle, there are some infectious encephalitides that present very subacutely, like TB meningitis sometimes, or fungal meningitis can present with very subtle neurologic signs and more like neuropsychiatric signs, personality changes sometimes. So that's something to consider. Biopsy is always helpful of some sort of tissue that's abnormal. In general, your cervical, axillary, and inguinal nodes are less diagnostic than thoracic and retroperitoneal nodes. Yeah, the hilar, mediastinal, and retroperitoneal nodes are the highest yield in general, but obviously less accessible. Bone marrow, if there are any hematologic abnormalities, looking for, especially helpful, disseminated mycobacterial and fungal disease and typhoid fever. Usually histopathology of bone marrow sections is more useful than culture, because the culture yield on bone marrow for these sorts of infections is quite low, but you should be able to stain it and see the organisms. But you should always send it for both. So in terms of diagnostic approach, there was this data from the Netherlands. They have an FUO study group. And what they focused on was potential diagnostic clues. So in their series of 167 patients, they found that after 1 week of admission, the majority of these patients had at least one diagnostic clue, which is something in the history, on the physical, or basic lab that pointed towards a specific diagnosis or an organ system. And then they were able to further direct their workup based on that. However, in about 61 of these patients, the diagnostic clues were misleading. And actually the likelihood of reaching a diagnosis was not significantly higher in patients with diagnostic clues versus without. Your chances of reaching a diagnosis were significantly lower in patients without a sustained fever, a normal sed rate, and a normal hemoglobin. And then they found that the value of most screening immunologic or micro or endocrine serologies were very low unless there was a specific diagnostic clue that pointed in that direction. The exception here were serum cryoglobulins. For whatever reason, they had a pretty high rate of cryoglobulinemia in this cohort, and thyroid studies. So they found that other evaluations that did have value in making the final diagnosis in people without diagnostic clues were an ophtho exam, temporal artery biopsy, bone marrow biopsy, and a CT chest and abdomen. So their conclusions were that random serologic testing was not really worthwhile, but rather following the patient carefully and monitoring for the development of diagnostic clues was of higher value. And reassuringly, all those people who didn't have a diagnosis, the majority recovered spontaneously, and there really was very low mortality overall, even in the absence of a diagnosis. And then therapeutic trials of anti-inflammatories or steroids or antibiotics are generally not recommended if the patient is stable, because they can delay the diagnosis and it confound things. If you do suspect a drug fever, obviously withhold the drug, and it can take 48 to 72 hours, depending on the drug half-life and the patient's status, hepatic and renal status, to see how quickly they clear it before the fever resolves. So, conclusions basically, so there's differing case definitions, but most of them require you to have a prolonged fever and no diagnosis after a minimal basic workup. The etiologies vary widely based on host characteristics, exposure history, geographic location, and which time period you're looking at actually. There isn't one single great test, but you should direct your workup based on clues in the H&P and your basic labs. And most patients with an FUO are going to be very stable, so you can monitor them and look for the development of clues rather than just sending a host of tests at the beginning. Something like PET scans or galliums, if you're totally lost, may help localize your disease process, but then you want to follow that up with specific imaging to characterize the lesion, and you may need to biopsy it afterwards. And like I said, most specialized testing is very low yield unless that patient has clues. And then prognosis varies, but it's really pretty favorable in patients with an extensive negative workup. And one study with 61 patients with an undiagnosed FUO, their 5-year mortality was only 3%. So more so in the outpatient setting, when you're talking to patients who have fever for prolonged time without an etiology, you can counsel them that most likely it's going to resolve spontaneously, and the chance of it being something serious that we don't pick up is quite low, and mortality rate is quite low. That was it.
Thank you so much, Dr. Gaikwad. Guys, if you have any questions, feel free to ask or type in the chat. Guys, I guess we don't have any questions, but thank you so much for this overview. It was really helpful. And thank you for joining and taking the time to teach us today.